Welcome back to another episode of This Month in Health. I'm Liz Ortiz. This month, November, is National Diabetes Awareness Month. According to the American Diabetes Association, over 38 million children and adults have diabetes in the United States. And in North Carolina alone, about 53,000 adults are diagnosed with diabetes every year. Joining me now to talk more about diabetes awareness is Dr. Susan Spratt, professor of medicine at Duke University School of Medicine. Dr. Spratt, thank you so much for your time today.
Well, thank you for having me.
Absolutely. So we are talking about diabetes awareness. I want to start with helping people understand diabetes, what it is, and how it impacts and affects the body.
So, diabetes is a disorder of glucose metabolism. Glucose is an essential molecule to our bodies. It gives us energy. So, inside the cell, it can be broken down and provide energy for the cell to do its business. But when you have diabetes, the glucose is not getting into the cells, it's staying out in the blood. So, colloquially, we say blood sugar because glucose is a type of sugar. So, if your blood sugar is high and it can't get into the cell, then that can make you feel tired. But it's really the damage that the glucose is doing inside the vessels that causes all the complications. So when glucose is high, it damages the vascular lining of all of the arteries and capillaries in your body, and then that can cause vascular disease and then in turn lead to complications.
Right.
The first signs of diabetes are actually a lot of times people are asymptomatic. But if your glucose goes above 200, you might notice that you are more thirsty or you're urinating a lot. You might have to get up in the middle of the night to urinate, or you can get blurry vision. You might find that cuts aren't healing as well. So, those are some signs that could indicate that you have diabetes. We don't want to wait though until your blood sugar is super high before you're diagnosed. We want people to be screened for diabetes so that we can treat it and prevent complications.
And when we hear about diabetes, I have several family members who have diabetes. So you hear about type 1 diabetes, type 2 diabetes, pre-diabetes, in pregnant women, gestational diabetes. We hear about so many different forms. Can you walk us through the different types of diabetes and sort of what each one indicates?
So, about 95% of Americans have type 2 diabetes, of those who have diabetes. And type 2 diabetes is a disorder of insulin resistance. So, typically, your body, if you don't have diabetes or a glucose metabolism problem, your body might need a certain amount of insulin. When you have insulin resistance, you might need twice or three times as much insulin. And what that means is your pancreas has to churn that insulin out. It gets tired and stops making as much insulin as you need to metabolize that glucose. And when that happens, your glucose goes up. So that's type 2 diabetes. It's associated with uh, um, obesity and sedentary lifestyle. But there are people who get type 2 familially, and they can be just slightly overweight and still be at much higher risk for getting diabetes. Type 1 diabetes used to be called juvenile diabetes because it used to occur mostly in children. Now we know that half of Americans who have diabetes, um, excuse me, half of people who have type 1 diabetes actually are adults.
Hmm.
Part of that is they were diagnosed as kids and they're living longer, but I've even diagnosed people in their 60s or 70s with type 1 diabetes. So we don't call it juvenile diabetes anymore. Type 1 diabetes is when your pancreas is not making any insulin. Your body has destroyed it by an antibody, and those antibodies kill the cells that make insulin, and then so you're reliant on insulin for the rest of your life. Um, and We have a lot of different ways to treat type 1 and type 2 diabetes now, but with um, type 1 diabetes, it's mostly going to be insulin and different insulin delivery methods that we use to treat type 1 diabetes.
And I know one of the methods, of course, is sort of an injection. Are there other types, or is that the main form?
Well, you can do syringe injections, so you can use a vial of insulin. You can do insulin pens, which are very easy to use, and you can kind of hide the little needle that's inside of it. And you can also do insulin pumps. And there are a variety of insulin pumps on the market. They do require training, and it's not just something you can put on and forget about. When you have diabetes, you have to think about what you're going to eat, when your next shot is, if you're on insulin, when you're going to exercise next. Every time of your life, really, you can't forget that you have diabetes. And so, but an insulin pump makes it slightly easier because you can have your insulin right there, so you can sit down, dial up how much insulin you're going to eat or use when you eat. And so it does make it a slightly easier to manage diabetes. And the insulin pumps are now somewhat automatic, so that if your glucose is going high, it will automatically increase the insulin, and vice versa. If your glucose is going down too low, it'll pull back on the amount of insulin that it's giving. So that makes it easier to manage diabetes when you're using insulin.
Right. And in the beginning, I talked about how common it is. About 38 million children and adults who have diabetes in the U.S. It clearly is very common. Are you finding in your practice that it is increasing in prevalence or even coming down in rates, or is it about the same? How would you describe it?
Well, I think diabetes has been increasing over the past 2 decades. So if you look at maps of the United States, in the 80s, I think the prevalence rate was around 5%, and now we're closer to 10 or 12% of Americans with diabetes.
And why? I was going to say, why would you say that is?
I think we're all sitting at our desks and not moving around. I mean, we are definitely a computer generation for the last 20 years. And so sedentary lifestyle is definitely a risk factor for diabetes. And the other issue is obesity. Obesity increases the risk of insulin resistance. And we know that I think it's now 75% of Americans are either obese or overweight, and that is a big drain on your pancreas.
Wow. I mean, it's true. So many people sit, even in my job, it's a lot of sitting, and you do it every day. I guess you don't really realize how much you're actually sitting.
Mm-hmm. Right. So one of the ways you can prevent diabetes is making sure you get at least 150 minutes of exercise in your week. That's not very much. That's just 30 minutes a day would get you past that 150 minutes. And it's just a brisk walk. So if you want to take your dog for a walk or walk to your mailbox several times, that's that all of that will help you prevent diabetes. And if you already have diabetes, it helps you manage your diabetes. So exercise is super helpful if you have diabetes.
Yeah, certainly want to stay moving. I'm sure you may have seen this recent study. It came out in the Lancet, and it found that nearly half of people with diabetes don't even know they have it, which I've found alarming. Why do you think that is, that so many people may not even know they have it? What does that say to you?
First of all, diabetes can be very silent. If your blood sugars are not super high, but high enough to hurt your body, sometimes you don't recognize it. Yeah. And so that's important to get screened. And a screening test would be one of three things. You can have a hemoglobin A1C checked, you can have a fasting glucose checked, or you can do a 2-hour glucose tolerance test. The A1C is the easiest because you don't have to be fasting, but it can be falsely low in some cases. So if you have anemia or any kind of hemoglobin problem or blood loss or recent surgery that caused some blood loss, all of those can cause the A1C to be falsely low. And so then you might be falsely reassured that you don't have diabetes when you do.
And what would you say, or why would you say early testing is so important in general, just to be able to catch it early, I'm assuming, but why would you say that is so important?
Well, we know when we manage diabetes and keep glucose near the target goal rather than have it go too high, we can prevent complications. We can prevent retinopathy and kidney problems. Retinopathy is bleeding in the back of the eye that leads to vision loss. And then you can also get problems with your kidneys that can lead to dialysis if not treated in time. And then the other thing is we have a lot of protective medications that help keep our bodies healthy if we have diabetes. That can be blood pressure meds like an ACE inhibitor or an ARB. Those are two classes of blood pressure meds that keep our bodies, our kidneys, our heart, our brain healthy if we have diabetes. This other thing is that we want people on cholesterol lowering medications. And if you have diabetes, we recommend a drug in the HMG CoA reductase class that they're commonly called statins. So rosuvastatin or atorvastatin. We recommend those because we know that they will prevent heart attack and stroke.
Right.
And so it's really important because people with diabetes have up to 4 times risk of having a heart attack than
Wow.
people without diabetes. So we want to start these meds early in the course of diabetes to keep bodies healthy. And basically that's our vascular health, is to keep all those vessels open and having blood flow without any plaques. That will allow us not to get complications. So the sooner we can start those, the better. And we don't put everyone on cholesterol lowering meds. But if someone has diabetes, it is a recommendation that you start a cholesterol lowering med. Even if your cholesterol has traditionally not even been that high, we would still start a cholesterol lowering medication.
Right. And I'm curious for people who listen to this and they have maybe a mom or dad who has diabetes or even an aunt or uncle or a close relative. Should that family history sort of encourage them to pay more attention to their risk factors when it comes to, staying on top of screenings and that sort of thing?
Yes. And, the American Diabetes Association recommends that if you are over the age of 18, overweight or obese, and have a family history of diabetes, that you are screened at least every 3 years. And like I said, that's a blood test, an A1C, or a glucose check, or a glucose tolerance test. We rarely do glucose tolerance tests, but there is a role for some of those. Um, but you should ask your doctor if you can be screened for diabetes. And a normal value is a fasting glucose under 100. And an A1C, a normal value is an A1C under 5.7. We haven't really talked a lot about pre-diabetes, but so diabetes is diagnosed if your A1C is over 6.5 or your fasting glucose is over 125, so 126 or higher. And pre-diabetes is if your A1C is between 5.7 and 6.4,
Hmm.
and your fasting glucose is between 100 and 125. If you have prediabetes, there are things you can do to prevent it from progressing to diabetes. So prediabetes progresses to diabetes about 1 in 10 people every year. There are many more people with prediabetes than diabetes. I think it's like 98 million Americans have prediabetes, and
Wow.
many of them do not know that they have it. And they may have been tested, and the values could be sitting in their medical chart, but no one has actually told them this indicates that you have prediabetes. So
Wow.
go back and get access to your lab work and see if you've ever had a glucose or an A1C check, and recheck it if it's been high, or even if you have other risk factors. Again, you should have it checked every year.
And for those who do have prediabetes or learn that they have prediabetes, can it in fact, because I've heard this, I don't know if it's in fact true, so I want to have you clarify, can it actually be reversed? And then if so, what are those small changes or differences a person can make in their day-to-day lifestyle to make that change?
So, prediabetes can be prevented from going on to diabetes, and you can drop down into the non diabetes or non prediabetes range with weight loss,
Hmm.
um, exercise 150 minutes a week, and eating a diet that's kind of like the Mediterranean diet. So, we want half of your plate to be green, a fourth the starch. The starch is what breaks down into glucose, and then a fourth the protein, and to really concentrate on increasing the green vegetables and the non starchy vegetables in your diet. will help reduce the risk of prediabetes going on to diabetes.
And aside from what we eat, how about what we're drinking? Does caffeine or even alcohol? How do these drinks play a role in the effects
Well,
of diabetes?
yeah, caffeine per se doesn't cause a problem, but if you're drinking it with a sugar soda,
Yeah.
it will. Sugar soda is a huge um, actor in promoting a high glucose, and sweet tea, especially the way some of our restaurants make it,
Yeah.
where it seems like it's half sugar,
Or
that's
almost
gonna
all sugar.
that will definitely provoke your blood sugar going up. Now, but alcohol is a very bad problem for the
Mm.
pancreas. It is like a poison to the pancreas and it's a poison for the liver. And both of those can impact your and increase the risk of diabetes. Also, certain alcohol, like mixed drinks or beer, have a lot of carbohydrates, and that can also raise your glucose.
How
If you don't,
about, oh,
yeah,
go ahead.
if you don't have diabetes, then drinking sugar drinks should not raise your glucose. But um, because we have so much insulin resistance in our population, it's not a good combination.
How about, as I'm guilty of this, so this is probably a question for me. I love to drink coffee, but the creamer, I almost can't drink it without it. But even that alone, just the creamer, I'm sure contains a lot of sugar, and it's something to be mindful of.
If it's just half and half or whipping cream, those aren't heart healthy, but they shouldn't raise your glucose. But if you're doing those creamers with the French vanilla syrup flavorings, yeah, that's probably something you should try to at least cut in half.
Yeah, good to know. And I'm curious with your patients, do you hear any common misconceptions when it comes to diabetes that maybe you would want to clarify or clear up when you talk to patients?
Yeah, sure. I think a lot of people feel like diabetes is a death sentence. They've seen grandparents or aunts and uncles get really severe complications. But with all of our new treatments and protective therapies, we can really prevent the vast majority of complications if we catch diabetes early. So, the number one thing is screen, find out your diagnosis, put a plan into action. And sometimes it's hard to stick to an action plan. Revisit it and say, how can I continue to have enough exercise in my life and to eat healthy and to keep thinking about how you're going to do that. Sometimes you need a coach, and that coach can be your doctor, or it could be a diabetes care and education specialist. It could be a health educator. It could be a group of friends that keep each other on track with their exercise goals. Um, but don't put your head in the sand. Get screened and get an action plan for your diabetes.
And for someone who is newly diagnosed, I'm sure there is somewhat of nerves and fear in that. What would their immediate next steps be once that diagnosis is received?
Absolutely go to diabetes care and education classes. So, diabetes self management education is super important. And only about 5 to 10% of people get a referral to a diabetes education class. And it really is something that's going to put you on a really good start. There's a lot of myths out there about diabetes, and some of them are not true. And if you find a myth that you think you should follow, and then you're not taught that that's not the right way to go about treating diabetes, it could really do you a lot of harm. So we really want to level set and make sure everyone has the right amount of education to take care of themselves.
And you mentioned the myths. Are there any in particular, maybe one or two that you find most common that you hear?
Yeah, so a lot of times I hear people say, okay, I've just been told I can't eat any food that's white. And what they're talking about, I think, is white sugar, white potatoes, white bread. And I want to go back to that. meal plate where we half the plate's green, a fourth is your starch, and a fourth is your protein. Obviously, if you're only eating carbohydrates, you've got to cut that in half. Add protein, add some healthy fat like olive oil or avocado. Um, but some people think I can never eat carbohydrates again, and that's not true. And it's really, we want you to eat a well balanced diet, which means a lot of greens, some protein, some healthy fat, and then some carbohydrate. And the carbohydrates that digest slowly, so that ones that have a lot of fiber, whether that's fruit or whole grains, over the fast acting carbs like white bread or white rice, will serve you better. But if for some reason you haven't eaten and you're over at someone's house and they serve you a piece of white bread, it's okay to eat that every now and then. We never say never when it comes to diabetes diets.
It's just managing, it seems like, for the most part, and reducing where appropriate.
Right. I think a lot of times people are overeating carbohydrates, but it doesn't mean they should take their carbohydrates down to zero. Now, there is a diet called, I think, that was popularized by Atkins, which is a low carb diet. I think now it's called the keto diet. It's basically the same thing, and people put their carbohydrates total in less than 20 grams per day. That is not my first diet when it comes to diabetes. I first say, let's just bring your carbohydrates down to a normal range per meal, which could be 30 to 45 grams per meal.
Right.
So much higher than a very low carbohydrate diet. If someone is not able to manage their diabetes by with that diet, and they want to use a very low carb diet, then I'm not going to say, oh, you shouldn't do that. But I would first suggest, see if your blood sugars are in goal with just reducing your carbohydrates to a normal level.
Perfect. All right, Dr. Spratt, we are going to take a quick break right there, but when we come back, we'll talk more about diabetes awareness, living with it, and also how family members and friends can support and encourage those who do have diabetes. So we'll be right back.
Okay, great.
Welcome back to This Month in Health. We continue the conversation with Dr. Spratt about National Diabetes Awareness Month. So, Dr. Spratt, I want to jump back into the conversation. I'm curious, for people who do have diabetes, they're on a treatment plan. What does, I guess, a successful day look like when it comes to managing diabetes? Where do they want to be as far as numbers and sort of having that good day?
So it really depends on who the person is.
Yeah.
So if this is a young person who wants to get pregnant, then we're going to say we want your glucoses to be very close to normal. And remember, I said normal was fasting less than 100, 2 hours after a meal, less than 120 if you're planning to get pregnant. But that's not the goals that we have for most people, unless they're able to get there without medication, or without medication that lowers the glucose too much. Because we also want to be cognizant that having a hypo, which is a low glucose reaction, hypoglycemia, can also cause problems. So if you are elderly with heart disease, we might just be happy if your fasting glucose is less than 130, and 2 hours after a meal you're less than 180. And we don't ever want to see a patient with heart disease have low blood sugars at all. We want, we'll tolerate low blood sugars in younger people who are able to quickly recognize the symptoms, quickly treat it, and not be at risk for fall. But once you're elderly and you might not be able to get to glucose or juice soon enough, or you might not be able to recognize the symptoms, because sometimes as you get older, you're put on medications that don't allow you to recognize the symptoms of low blood sugar. Our target's glucose goes higher. And so typically we want to see an A1C in a young person around 6.5. But in an elderly person, we might even go up as high as 8.5 if they have a lot of medical problems and their life expectancy is less than 2 or 3 years. So it really depends, and it's a discussion that you should have with your doctor and your diabetes care and education specialist. And it will change as you age and different things, and there may be different priorities for you.
And when it comes to diabetes, are there any common challenges that patients may face? And if so, how do you, as the provider, as their doctor, motivate and encourage them through that?
Okay.
There's so many challenges with diabetes, it's hard to pick which one. But, and so as a physician, what I try to do is ask the patient, um, where they're doing well and congratulate them on that. And then ask them, what do you think we need to work on? Because patients are more likely to want to work on something they've identified than if I identify it for them.
Right.
I need to help them identify what they might want to work on. And then we go through this process of trying to have the patient decide how they're going to fix that problem. Because, if I just tell people, oh, you should do yoga, I love it, and they don't like yoga, that's not a
Right.
very good thing to do. So we set a goal of exercise, but I wouldn't say to someone, oh, now you need to go run 3 miles a day. That's something we work with the patient to say, what do you like to do? And before we talk about exercise, if you aren't exercising at all, you need to see your doctor to make sure it's okay for you to start an exercise program. Um,
And I'm curious too, with friends and family, how can they, or what's your advice to them in supporting a loved one who has diabetes?
this is hard because you want to not be a nag. No
Yeah.
one wants to live with someone who's constantly berating them. So I would say support by making sure there are healthy choices to eat in the house, removing the things that aren't healthy to eat, like junk food, um, making sure patients are able to afford their medications. They might, if you have an elderly parent who is unable to pay for copays, you might want to visit what's called the SHIP company in your county. There they can help you figure out, based on your health plan, what is the best medical regimen for you. So they might look at one of your meds that's costing a lot of money and find out, hey, your insurance pays for a different medication in the same class. Let's ask your doctor to switch you to that. And sometimes that takes an adult child's advocacy for their parent to be able
Right.
to do that. Um, Recognize that copays are really high, and patients with diabetes are on a ton of meds. So even if one copay isn't very expensive, once you're on multiple meds times that copay, it can get quite costly. So recognizing that can be helpful. And also setting exercise goals, maybe exercising with a friend who's struggling.
And you mentioned the cost. When I was doing research and just looking at the American Diabetes Association, it said that the cost burden alone of diabetes and the medications really is a lot on so many patients.
It's huge. And unfortunately, that's not getting better anytime
Mm.
soon. But you can do things like look for medications that your insurance company is covering. In this state, Medicaid for patients with diabetes, Medicaid pays for every class of medication for diabetes. So, and so the real problem is for patients without insurance, and then also patients with Medicare. They can't get coupons for some of their expensive medications like the GLP-1s or the SGLT2 inhibitors, and so that can be costly.
Right. We discussed a bit, and I want to get more into it. Tell us about some of the local and national resources that patients can turn to if they need any sort of assistance when it comes to learning about diabetes, managing diabetes, finding any sort of support for it.
Right. So the North Carolina Diabetes Advisory Council is a statewide advisory board for diabetes, and we edit a book every 5 years as a resource. So I can give you that link and you can put it in the podcast. In that book is it's called the Diabetes Guide. It's a guide for the prevention and management of diabetes. So it goes through a ton of advice, and we've only touched on a small amount of that. But it also has a page of resources. So beyond that being a resource, it also has another page for other resources. The American Diabetes Association website also has some very good recipes on their website for patients with diabetes. And then if you have a patient or a loved one with type 1 diabetes, it used to be called the JDRF, which was Juvenile Diabetes Research Fund, is now called T1D, Breakthrough T1D. So you can look for that as well.
And just important for people to know that there are, in fact, resources and multiple, it sounds, for them to turn to.
Yeah, and when you go to the diabetes care and education specialist, those classes, the diabetes classes I was talking about, they will know more about resources in your county. The YMCA often does pre-diabetes classes. So if you have pre-diabetes, ask for enrollment in a diabetes prevention program. The YMCA across North Carolina is employing those classes as well.
Well, Dr. Spratt, before I let you go and as we wrap up the conversation, any one final piece of advice or message to people for National Diabetes Awareness Month? Any one thing we can all start doing to just live a better and healthier lifestyle?
I'd say get screened, know your numbers, and besides your glucose or your A1C numbers, blood pressure, control your blood pressure, get adequate sleep, don't smoke tobacco, and if your doctor asks you to use a cholesterol-lowering medication, don't say no.
Perfect. All right, Dr. Spratt, thank you so much for your time today. Such an important topic, but I think we've got a lot of great information to share with people, so we do appreciate it.
All right, it was so nice to talk to you.
Great. Thank you so much. And that'll do it for this episode of This Month in Health. I'm Liz Ortiz.